Thanks for joining us for the next in our series of In Conversation With. This time I'm speaking with London-based surgeons Ash Kathari and Hisham Hamed from Guy's Hospital, as well as Masi Kariati and Petros Charalampidis from University College London Hospitals. Now, I wanted to speak to these four surgeons because they've all been instrumental in help setting up the London Cancer Hubs. These are surgical sites that have allowed essential breast cancer treatment to continue throughout the last few months. In this first episode of 2, we discussed the setting up of the hubs, the sheer cross-hospital collaboration that's been required to get the first patient in the door, and also the challenges they've navigated throughout the last few months, most notably maintaining a world-class standard of care in breast cancer treatment, and also keeping their patients safe and COVID-free. To start with, could you tell us about how COVID has changed the way your teams operate at both UCLH and Guy's Hospital?
When the pandemic news broke and there was this hysteria around everyone getting it, there was a sharp fall or decline in the referrals because patients themselves found it risky to come to hospital. We also went to whatever referrals came through, we went to a system of triaging these referrals and making sure that these are the patients that need to be seen. Rather than a young patient with breast pain, we would reassure them and ask them to wait for 6 weeks. If their symptoms persisted or they found any clinical findings, then they should present to a breast clinic.
Here at UCLH, we had a particular challenge, and that is we have a very large ITU, which enlarged significantly in preparatory response to the COVID pandemic, and that withdrew resources from our operating theatres. And so early on, we asked ourselves the question whether would there have been a sort of a better way of delivering care that would have kept our cancer patients safe from the risk of COVID, but also safe in that cancer care would continue to be delivered. We identified the opportunity to perhaps consider transferring at least the surgical aspects of our care to the neighbouring independent sector, particularly the Wellington Hospital, where several of us had experience from having worked there before. And we were very lucky in that the Wellington welcomed us to sort of facilitate this.
What was more important that came to the fore was we really pulled together as a team. So there was a lot of communication going on between the administrative team, the surgical departments, radiology, making sure the patients are in the loop. Our junior doctors really contributed in a big way in the triaging system and the telephone consults with the patients.
There has been also fantastic collaboration between the NHS and the private sector, which something I have not actually experienced during my career. And that is no question that has allowed us to continue with our work to the best possible way, as well as delivering the best possible care and the safest care for our patients.
As you say, there's been a lot of support and collaboration with the private sector. But also there's been a lot of collaboration between individual NHS hospitals, something that's not happened a lot in the past. Can you tell me a little bit more about that and how just that collaboration has helped set up the hubs and get the first patients in the door?
And so the hub here at UCLH identified 3 sites, the Wellington, the Westmoreland Street Hospital, which is in Marylebone, and it's part of the UCLH group of hospitals, and the Princess Grace, another HCA independent sector hospital, and various specialties were distributed amongst the 3 sites, where we had the opportunity to establish a pathway for the management of our breast cancer patients to keep them safe from the additional surgical risk related to the potential coexistence of COVID or having contracted COVID and not yet having displayed symptoms, and to then proceed with the cancer treatment, hopefully without delay.
The Southeast Cancer Network and Royal Marsden were instrumental in bringing various networks together, and we have formed the London Hub, which was guiding more of a kind of an advisory role. And one of the things that we managed to achieve was we were the first hub or region in the UK to start with immediate breast reconstructions. Because we looked at the safety, we looked at availability, and then we said, yes, there's no reason why we shouldn't be rolling this out.
And by hubs, we mean centres which were to be kept COVID-free or as COVID-free as possible, and whose resources were to be utilised primarily for the delivery of cancer care, and that would have run in parallel to the efforts to tackle the COVID pandemic on the acute respiratory front, which would have remained at her base site at UCLH.
The creation of a hub in itself was a challenge because you had to bring together trusts and subspecialties that didn't used to work together before COVID. So we kind of established a new norm, and now amidst of it, we're coming more mature out of it gradually. So what happened is that you needed 2 points of orchestration. One was a Pan-London hub meetings that Masi continuously led and participated on a weekly basis, which were prioritizing patients for surgery. So we established a framework of guidelines to be able to give breast cancer surgery to patients that need it the most as an ultimate priority, based on clinical aggressive behavior, based on biological features, based on patient fitness, for example. And all these cases went through the main hub. So we established, at the same time of establishing a physical hub, the premises to operate on the patients, we designed meetings that were fundamental to prioritizing patients who had surgery.
I think we all feel very proud that at no time under these exceptional circumstances, the patients have been compromised. I mean, I'm sure that during that journey, some of the patients may have felt aggrieved, or they did not feel that they're getting the support, but at every decision and at every level of the decisions, the patient safety has always been the priority.
You had to be able to bring all the subspecialties, all these technical challenges all together and, make them operate and work together smoothly in a way that 11 trusts in one hub could do safely breast surgery throughout the week.
So I think your question was, have you ever witnessed this kind of collaboration? And the short answer is no.
No.
I think the NHS and surgeons by design have been a competitive breed. So trusts compete with each other and who does the most reconstructions and who sees the most patients. And this was driven by various factors. I think this is the first time I've witnessed where Pan-London, you've seen that the patient was put first, truly patient-centered care. It was all around the patient. Clinicians, priorities, egos, hospital names and badges was all thrown aside. All the clinicians pooled together and put the patients first, prioritize the surgeries that need to be done. Radiologists pulled together, and again, they've collaborated.
Well, it sounds like you guys have managed incredibly well given the circumstances. Beyond the difficulties of setting up the hubs, have there been any additional challenges specifically relating to breast surgery practices?
Now, with that sense, obviously, there came the challenge of what do we do with localizations when it comes to non-palpable breast cancers.
Quite a significant number of our patients, for example, require localization for non-palpable lesions. And our routine practice is to insert a wire in the breast. That in itself has obviously its limitations. We cannot, for example, do it any earlier than the day before. And we cannot actually send the patient for any reason. If the patient has to be cancelled, we couldn't send the patients home with the wire in their breast.
We have to rethink the whole concept all along to be able to accommodate patients who have only the surgery in the hub, but having all the preparation beforehand. So we had to come up with a plan, and I think that the Maxid in that sense helped a lot because essentially if we were to place wires to all of these patients, obviously the resources for doing that would be much more challenging. Whereas by liaising with the radiology colleagues on site at UCLH, for example, we would identify these patients ahead, some weeks ahead, and we would plan in place their slots for having their Maxids before the surgery. We would have adequately discussed them in our local MDT to ensure that they need Maxid and that the review of imaging has been complete. And therefore, the patients would come to the date of the surgery ready for a localized wide local excision, for example.
And so to try and also facilitate reducing the need for travel, which of course at the height of the pandemic was certainly a concern with regards to moving in between sites. we thought that Maxseed allowed us to do that, because it allowed us to carry out localizations in advance on called lists on site at UCLH, at a site that was anyway maintained as COVID-free or COVID-green, as it's been called more recently, and still get the patients treated at the Wellington either a few days later or the following week, or sometimes 2 or 3 weeks after localization. So that was instrumental in being able to continue delivering breast-conserving surgery in patients with non-palpable breast cancers, but also not affect our workforce. So it did play a key role in allowing the hub to function from a breast cancer care perspective, certainly for UCLH.
I think he's absolutely right. If there's any question about anesthesia, I'm happy for that seat to stay in there for the next 6 months and not bother about it.
And also what practice shown is that we knew that already, but we saw it unfold in practice and becoming really relevant during COVID, is that we had a few patients, hopefully, fortunately that was a minority, that were to become COVID positive on the swab. So therefore these patients, should they have had a wire, it would be extremely challenging or almost impossible to do to cancel the surgery on the day with a wire in place. So therefore, the tackling of this problem would be maybe unsurmountable within the COVID era. Whereas with the Maxseed in place, we allowed ourselves the option or the possibility to have a patient COVID positive and reschedule safely without any impact on the patient herself.
In whatever procedure we do, we ensure that the patients have been COVID-free. But certainly when there is no wire sticking out of the patient's breast, that given this flexibility to reschedule the surgery without compromising the patient.